So this is part 2, the types of childhood cancers, starting on, I believe it's slide 20. So leukemia. Leukemia is cancer of the blood-forming tissues. There is a peak onset age. It's about ages between 3 and 5 years old. Basically what happens is that abnormal white cells, which are the immature cells or the blast cells, end up crowding out the normal cells in the bone marrow. This is what causes leg pain. That's where the major bone marrow production at this age is in those long bones in the leg. It's in multiple places, but it's the long bones of the legs, and so it can cause pain as there's a bunch of blast cells in the bone marrow. When the immature cells keep proliferating, keep dividing over and over, what it ends up doing is it leads to lots of white blood cells, but they just don't work. There's less red blood cells and less platelets. These are crowded out by those normal cells. And the immature white cells, as I just kind of mentioned, they're not normal. They don't fight infection as they should. Signs and symptoms of leukemia are frequent infections, fever, enlarged lymph nodes, and pain. These patients often look pale because of their anemia. They're weak, have fatigue, loss of appetite, all of those things because of being anemic, and they're often short of breath. They have easy bruising, bleeding that's difficult to stop, and petechiae, all because of having the low platelets. Petechiae are the flat, pinpoint red spots that are due to bleeding under the skin. These are the ones I've talked about before that are non-blanching. So when you push on them, when you push on your skin normally, it blanches. It looks lighter and then gets darker again to your normal skin color. And that happens on bruising and other things. But with the petechiae, when you push on it, it doesn't change at all. It stays the same color. Another big sign of leukemia, but it's obviously not just with leukemia, is hepatosplenomegaly. So both your spleen and your liver are bigger, and you can feel them pretty well underneath the rib cage. They stick out beyond the rib cage, that's why you can feel it well. So there are lots, actually, of different kinds of types of leukemia. But we're going to talk about today, we're going to limit it to ALL versus AML. So ALL is acute lymphocytic leukemia, and it affects the lymphoid cell line. So you can see in this picture that the lymphoid cell line versus the myeloid stem cell line. You can see that the lymphoid cell line affects this much, whereas the myeloid stem cell affects this much. So the acute lymphocytic leukemia, ALL, actually is easier to treat and has a better survival rate. Their survival rate currently is actually greater than 90%, which is amazing, actually. Back in 1948, a child with ALL only lived 2 to 3 months, and now the survival rate is 90%, 10-year survival rate. And AML, acute myelocytic leukemia, acute myelogenous leukemia, it has lots of different names. It affects the myeloid line, which is here. There are multiple types of AML, but we're definitely not going to get into that at this point in your education. But the survival rate is only about 65%. The diagnosis and treatment of leukemia. So CBC can give you a clue that something's going on. So there shouldn't be any blasts in the peripheral blood. So if blasts are detected on a CBC, that's abnormal and leukemia should be suspected. And diagnosis is typically made by bone marrow aspirate and biopsy results. So we talked about earlier the process of we talked about in class actually, bone marrow aspirate and biopsy, how it's done. But basically, when the results come back, it will tell you if it's leukemia, and if so, the type that is determined under the microscope in the lab. And it's a very complex disease classification system, but that goes beyond the scope of this class, so we're not going to talk about that. Basically, you should just know what leukemia is. And some of the treatments. So the treatment for ALL it's 3 phases of treatment. Treatment lasts actually 2.5 to 3 years. It's actually a little bit longer in boys. And that's because the scrotum actually is, so it's described to me as a good hiding place for leukemia. So this boys can have scrotal involvement. Obviously, that does not affect girls. And because of that, their treatment is a little bit longer. The 3 phases of treatment for leukemia are induction, consolidation, and maintenance therapies. In induction, you get intense chemotherapy, and the goal is to put the disease in remission. And typically, they do go in remission in that first month. It's associated with a poor prognosis if it takes longer than a month to get them into remission. Then you go into the consolidation phase, and then they give different chemotherapy, a different regimen to rid the body of any remaining cells that may eventually grow and cause the leukemia to return. And then once you get through that phase, you start the maintenance phase, and this is less intense. The therapy is given much less often. The goal is to destroy any malignant cells that have survived the first 2 phases. And like I said, the entire thing lasts about 2.5 to 3 years. AML's treatment's different. There are actually 2 phases of treatment, and the treatment lasts about 3 years. It starts with induction, which is the same. You give very intense chemotherapy at the beginning to try to put the disease in remission. And then you go into consolidation therapy, which is different therapy to try to kill anything that has remained. At this point, depending on lots of factors, they may or may not do stem cell transplant. It depends on the subtype of AML and then basically how therapy has been going. And lymphoma is also a disease of the immune system. And there are two that were different subtypes. There's Hodgkin's disease, or Hodgkin's lymphoma is another name for it. And everything else is called, every other kind of lymphoma is called non-Hodgkin's lymphoma. So in talking about Hodgkin's disease, it primarily involves the lymph nodes. It progresses in a pretty predictable manner to the spleen, the liver, bone marrow, lungs, and the mediastinum. Remember that the mediastinum is essentially everything that falls in between the lungs on both sides. So the middle area of the chest. This Hodgkin's disease typically it's a teenage disease, typically between 15 and 19 years old. In non-Hodgkin's lymphoma, this is actually more common in the younger kids, not as much in the teenagers. And 20% of these actually start outside the lymph nodes, and these are much more unpredictable than the Hodgkin's diseases, or than Hodgkin's disease. The signs and symptoms of lymphoma in Hodgkin's disease is characterized by non-tender and large lymph nodes. The classic symptoms, which are actually only seen in about 30% of cases, but these are the classic symptoms of Hodgkin's disease, are fever, weight loss, and night sweats. It's unexplained weight loss of greater than 10% within a 6-month period, and unexplained fevers greater than 100.6 degrees. And these night sweats are not just, like a little, we have too many covers, sweating a little bit in bed. Like, these are drenching, like, get out of bed, change your sheets type of night sweats. These patients with Hodgkin's disease are treated with chemotherapy. The tumor also responds well to radiation therapy. Typically, these patients get mantle radiation. There are a lot of studies going on to try to see, to kind of determine who needs it and who doesn't, because, radiation really has lots of long-term effects. So it's better not to give it if possible. In non-Hodgkin's lymphoma, so 60% of lymphomas are non-Hodgkin's. Their symptoms are coughing, wheezing, trouble swallowing, testicular masses, weight loss, night sweats, and fever. These patients can also have itching as a side effect. And that happens about 15% of the time in non-Hodgkin's lymphoma and about 30% of the time in Hodgkin's lymphoma. They're not sure why, but it's a side effect of these lymphomas. The non-Hodgkin's lymphoma, their treatment is with chemotherapy and then radiation, but really radiation is rarely necessary in non-Hodgkin's. It's used much more in Hodgkin's disease. The Hodgkin's cure rate, though, is 95%. So these patients typically do really, really well. Even with the advanced disease, these patients have a cure rate of 90%. Hodgkin's disease, non-Hodgkin's disease, the cure rate is lower, 80%. One thing I wanted to mention is that, which doesn't necessarily pertain to lymphomas, but when you have the supraclavicular lymph nodes, when those are palpable, so these are the ones that just are right above your clavicle, right above your right above your collarbone. Those are not normal. They should always be, if you can feel them, they should always be investigated because they're most likely malignant. And here's just a picture that shows you these little lymph nodes and what they can look like in Hodgkin's disease. So moving on to the brain tumors, the CNS tumors. These are solid tumors in the brain or spinal column. They make up about 20% of all childhood cancers, and they are classified by the type of tissue in which they begin. For example, astrocytoma come from astrocytes, which are cells that form the supportive tissue for neurons. Diagnosis is based on MRI findings or other biopsy results. A lot of times, these it totally depends on location, whether or not these cancers can be biopsied. And if it's in a place that can't be biopsied is when you base your diagnosis on MRI findings instead of going in there and trying to get some out. Your signs and symptoms, the most common are headache and morning vomiting due to the intracranial pressure. You're seeing your increased ICP. And you can have other signs and symptoms that are just totally based on location. And people who work with children with brain tumors really know the anatomy of the brain well and can tell you exactly what signs and symptoms to expect based on the location of the tumor. Table 31-4 on page 1407 in your book go over these for you. So in infants, CNS tumors might be hard to pick up. And why do you think that is? It's because the cranial sutures are not closed, so the brain can expand to accommodate the tumor, whereas in children who have the cranial sutures are already closed, it just causes increased pressure when these tumors get bigger. Because as you can imagine, like these tumors, there's not much space in there. So they really start causing problems quickly. Treatment of brain tumors are typically a combination of surgery, chemotherapy, and radiation. Surgery can be dangerous because it really can cause injury to important areas of the brain. There's really just no room for error in such a small space with so many important structures around it. Radiation is a problem because it can cause tissue necrosis, so it can cause tissue death, scarring of the tissues around it, scarring. It can cause behavioral or intellectual deficits. You know, in pediatric patients, they have so much brain growth left, and so when you give them radiation at a young age, it can really cause some long-term behavioral and intellectual problems. It can cause endocrine dysfunction, you know, because of the endocrine, because of the different endocrine structures in the brain, and radiation can cause secondary malignancies, secondary cancers. So proton beam radiation is becoming much preferred for treating brain tumors because the proton beam radiation provides a more focused beam of radiation, which decreases side effects. The blood-brain barrier is an issue when it comes to treating brain tumors. So it really reduces the effectiveness of chemotherapy because, you know, the blood-brain barrier is supposed to protect the brain, right? So in doing that, it keeps some of the chemotherapy from getting where it needs to go. So one way of getting past the blood-brain barrier is to put in a Maya reservoir. And basically what this is, imagine it kind of like the port that we talked about that goes in the vein in the heart. This actually is it's surgically placed under the scalp, and it delivers chemotherapy directly into this CNS system. So it looks kind of, from the outside, it looks kind of like a port on the child's head. And you're able to put a needle in it and give chemotherapy through that to give a higher dose to the brain that the blood-brain barrier typically is protecting. It's a way to get around it. So Wilms tumor is a nephroblastoma, is the other name for it. So as you can imagine from the words nephro, this is a a tumor in the kidney. It can affect one or both kidneys. The peak incidence is 2 years old. Some are inherited. About 5% can be an inherited disease. But most are random. 95% of them are random. These present as a painless mass within the abdomen. They're often found by the parents when bathing or dressing the child. So they can just see that it looks different on one side than the other because the tumor starts, it gets big enough that you can see it, and it kind of pushes the skin outward. The signs and symptoms of a Wilms tumor. So the most common signs and symptoms are a non-tender mass. The patient otherwise is well. Sometimes they'll have a little bit of blood in their urine, or present with anemia or hypertension. So treatment is removal of the affected kidney, and chemotherapy with or without radiation, depending on the situation. The kidney is removed because the kidney typically looks, the kidney doesn't work anymore. The tumor has just really invaded, and it looks like this big, in pictures of it, it basically is this big, it's a huge tumor that doesn't resemble a kidney anymore at all and really just has no function left in it. So the whole thing is taken out. Long term, these kids, they only have one kidney, so they need to protect that kidney. So they need to avoid contact sports. And then if they have any symptoms of UTI, it needs to be detected promptly and treated to protect that remaining kidney. One thing that I feel like the book kind of overemphasizes, which in practice doesn't happen, or at least didn't happen where I worked, is that it talks about how you just should never palpate that tumor because it's at risk for rupture, which is definitely true that the tumor is typically encapsulated, so it doesn't. And so when you take it out surgically, you can usually take it out fairly easily. And you definitely don't want to rupture it because it makes the prognosis a lot worse. Because as you can imagine, if it ruptures, it spreads tumor cells throughout the abdomen. But actually just talked to the doctor that I used to work with about this because I didn't ever notice that it was a big deal not to palpate the abdomen. We did it. And her response was, well, how hard are you really palpating this kidney or palpating this tumor? Like, you shouldn't really be pushing on it that hard in the first place when you're doing your evaluation. So it's definitely not something that you need to worry about not touching. But we should always be gentle with these patients. A neuroblastoma is an abdominal tumor also, like the Wilms tumor, but this is a cancer of the sympathetic nervous system. So while it typically happens in the abdomen, it doesn't have to. It can happen anywhere along the sympathetic nervous system, but it typically happens around the adrenal gland, which sits just above the kidney. The median age for diagnosis is 22 months, and this is a silent tumor. About 2/3 of kids have metastasis at the time of diagnosis. And the reason why it's considered a solid tumor is because, or a silent tumor, is because, the abdomen is just so big. Or there's so much space in it compared to other places in your body. So it can really grow and become pretty big before anyone even notices. So many parents often end up feeling guilty or angry with their providers for not catching it sooner before it's metastasized, but it almost always metastasizes prior to diagnosis. One thing I also think you should note about neuroblastoma, it makes you think, at least when I first started, I thought it had something to do with the brain because of the neural part, but it is not a brain tumor. You can see from this picture that about half of them start at the adrenal gland, and then so that would be abdominal, and then in the paraspinal area, about another fourth of them. So you can see probably about 3/4 or 2/3 of the time, it starts in the abdomen. And you can see otherwise it can start, the green is chest, sometimes it starts up in the neck, and sometimes it starts in the pelvis, but that's the least likely. Signs and symptoms of neuroblastoma totally depends on the location. But typically the kids might have abdominal pain, they might be throwing up, have weight loss, fatigue, and bone pain. They are not well appearing like kids with Wilms tumor. They come in looking sick. The kids with Wilms tumors, have this big tumor on their side, but they look fine and well. Neuroblastoma kids, it's more of a systemic disease, and they're sick. The treatment is totally stage dependent. It varies from observation to very intense chemotherapy, which includes chemo, radiation, stem cell transplant, antibody therapies, MIG therapies, just really a lot of therapy. The prognosis in kids under 1, these are the kids that can be observed a lot of the times, and a lot of times it will just go away on its own. Under 1-year-old, 95% of them are cured. Or if the kids are older than 1 but have localized disease, they still do well, about 85% of the time. Kids that are over 1-year-old and have metastatic disease only live 50% of the time. This is really a terrible disease. You can see here, this is where the big tumor is on the adrenal gland, and it's big like this. And this is what it looks like from the outside. Like, they have these huge distended bellies that are very hard when you palpate them. And then in the babies, this is something that's unique to the babies. 1 or under, they call them little blueberry spots, and they actually look blue. And they have these little skin lesions that can appear anywhere on the head, and those often need some therapy, but they do really well. They live 95% of the time. Osteosarcoma is a bone tumor. You can see the osteo in the word. It is the most common bone tumor in children. And when I say common primary bone tumor, it means that it starts in the bone. Some of these diseases can actually metastasize to the bone, but this is a tumor that starts in the bone in children. The peak age is the teenage years. It is likely secondary to a high cell turnover rate during the adolescent growth spurt. And some interesting things about it, I thought, were that patients with osteosarcoma are typically taller than kids their age. The risk of osteosarcoma is much higher in breeds of large dogs, like the Great Danes and St. Bernards, than of smaller breeds. Those larger breeds of dogs get osteosarcoma 185 times more often than the smaller breeds. There's a 185 times risk in the larger dogs than the smaller dogs. And it typically occurs at an earlier age for girls, which corresponds with the earlier growth spurt. Remember that girls go through puberty a little bit earlier than boys, and they have their growth spurt a little earlier than boys, and they end up having osteosarcoma a little bit earlier than boys do. Osteosarcoma most often occurs in the rapidly growing bones, in adolescence. So it typically happens around the knee, the distal femur or the proximal tibia, or the proximal humerus, so up in the shoulder. Typically at diagnosis, kids don't have metastasis, but about 15 to 20% of kids do at diagnosis, which leads to a poorer prognosis. Anytime that the disease has moved and metastasized, there's a much higher risk of not doing well. So the prognosis with localized disease is a 70 to 75% survival rate, and it's 30% if they have metastasis. Treatment for osteosarcoma is that, first of all, the definitive diagnosis is by biopsy. And the biopsy, one thing that you should understand is that the biopsy needs to be done by a surgeon who's going to do the surgery later. And the reason for that is, when you cut in to do the biopsy, you're going to potentially contaminate the skin with tumor cells. So you want to, when you go in to do the bigger surgery later, take that whole area out. So the person who's doing the bigger surgery ideally should do the biopsy too. Surgery has a key role in treatment. Only 10%. There's only 10% survival rate when you give chemotherapy alone. I had something very similar to osteosarcoma. I had the actual osteosarcoma therapy, and the way it was described to me is that my doctor said you always take out home base. The place that it started always needs to come out. So these patients do lose a body part from their tumor. Treatment is preoperative. You do preoperative chemotherapy to ideally shrink the tumor as much as possible, so that the surgery doesn't have to be quite as big of a surgery. So you do your chemotherapy, you do surgery to remove the area that the cancer started, and then you do maintenance chemotherapy for 6 months to a year. And the way that was always described to me also was that it's kind of like an insurance policy. Like, everything seems to be gone as far as you can tell, but there still might be something there, and so you do chemotherapy longer to try to get rid of whatever is remaining. Surgery can involve a limb-sparing surgery or an amputation, and you can see in this sweet little girl right here, who was one of my patients, her parents gave me permission to use this photo, ended up having an amputation. Limb-sparing surgeries are what they sound like. You spare the limb by putting in some sort of metal rod or some sort of cadaver bone or something to replace what's taken out. Sometimes it is great. It totally depends on location. Sometimes amputation is a better option. And when I was a young nurse, I just didn't understand that. It seemed like limb sparing would always be a better option to remain, as normal as possible. But what I've seen over the years is that, these patients, depending again on location, these prostheses, after an amputation, sometimes they're so good that they really are just so much more functional than keeping the limb and then having it not work as well. I had a patient who his osteosarcoma was lower in the leg, so they removed. He was able to just have his own. He had his own knee that was unaffected, and then the lower part of his leg was a prosthesis in the foot, and he was able to play varsity basketball. Whereas if they would have spared the limb, he would not have been able to, because the prosthesis, the rod that they put in, typically can't take the jumping and the different trauma involved in playing basketball, jumping up and down, those types of things. So again, it definitely depends on location, whether or not the prosthesis is more functional or not than actually sparing the limb. And then long-term effects. So long-term effects are limb function and fertility. One thing that's different about osteosarcoma than most of the diseases is that radiation is not used in osteosarcoma because it doesn't work. Osteosarcoma is radio resistant, so it only works in super high doses. So sometimes you can use it just for palliative reasons. If the tumor is causing pain, you can give it really high doses of of radiation therapy. But it's typically not used because it really doesn't work very well in osteosarcoma. Nursing considerations, with amputation or with any surgery that involves the loss of a body part, is to be really supportive during the planning period and to answer questions honestly. Remember in pediatrics and probably any sort of nursing care, but just always answer their questions honestly. But one thing I've found in working for many years now is it's best to let the parents take the lead in answering the questions when they're present. If the patient asks you something and the parents aren't there, obviously you're the one that needs to answer it. But unless it's completely directed to you and the parents are looking to you to answer, I always found it best to let the parents answer the questions and support what the parents tell them. One thing to consider is to never tell them that they're going to be cured or that there's any sort of therapy that's going to guarantee the cure, because it doesn't. Some of these cancers have such great survival rates, but like Hodgkin's disease, for example, 95% cure rate. But someone is that 5%, and it very well might be the patient in front of you. And so, there's no guarantee that they're going to be cured. So never tell them that. Always offer to talk. But remember, you should mostly listen. Let them vent. Let them talk about what they need to talk about. Allow them to grieve. Allow them to be angry. There will probably be some times of depression also that they may need. They'll definitely need your support, and they also will potentially need psychology or psychiatry to help them get through. The prosthesis, can cause issues. These kids have a lot of growing to do a lot of times, so they need to be revised. They need to be refitted. Sometimes they just get worn out from all the use that kids put these prostheses to. So a lot of times they'll just need the prosthesis redone. And then phantom pain is something to always think about with amputation. So basically what happens is, the leg is removed, but those nerves coming from the spine are, part of them are still there. So it makes it feel like the limb is still there, although the limb is not there. And there are different drugs you can use to make that pain go away. But it's definitely a very real thing when they tell you that it feels like their leg is still there. It's called phantom pain. And one thing I also wanted to bring up is that my doctor, and I feel like this has worked well for me, my doctor never really talked in terms of stats. So, the parents will ask you, what the cure rate is, what the chances are of them doing well, because they're worried and they really want to know. But one thing that my doctor always told me was that he never talked in terms of the stats because it doesn't matter. For me, the stats are 100% or zero. It doesn't matter that 70% of people do well when you're in that 30%, or 95% of people do really well, so you expect to do well, and then you happen to be in that 5%. So as you start working, you can handle that in any way you'd like, but I have found that it's definitely better not to talk in terms of stats. Rhabdomyosarcoma is a soft tissue sarcoma. You can see myo in this word for the muscles. It develops it can develop in skeletal muscle, but it can arise from almost any anatomic site. 2/3 of their cases are in kids under age 6 years old, and the most common site is the head and the neck. But it's also common in the genitourinary tract, the GU tract, the extremities, or in the orbit of the eye. So the signs and symptoms are dependent on the site. Often they're vague symptoms. They can have, a lump or swelling that does not go away, bleeding in the nose, the vagina, or the rectum, constipation. They can have proptosis, which is the bulging of an eye, or both eyes, and they can have headaches. But the most common presenting symptom is a painless mass. The staging is really complicated, and we're not going to get into that. The treatment is surgery, chemotherapy, and radiation. They can do external beam radiation or brachytherapy. And what brachytherapy is when you use needles and little radiation seeds and wire. And what happens is they surgically insert little catheters, so little tubes directly around the tumor site, and you put these radiation beads in the tubes, so that the radiation goes directly to that site. That's one option, and that's what brachytherapy is. The survival rates for rhabdomyosarcoma depend on the tumor size, the location, and the amount of tumor that can be removed. The survival rate is greater than 70% in children that have localized disease. It's much less. The survival rate's much less than kids with metastatic disease. Retinoblastoma is a malignant tumor that arises from the retina. It's an eye tumor. The average age of diagnosis is 2 years old, and this is a rare disease. It's about 200 cases a year. It can be inherited. The signs and symptoms are typically leukocoria, which is the cat's eye reflex. So basically, what that is when you shine a light in the eye, it glows like a cat on the one side. Normally, it should look like this, or you have the red reflex, where it looks red when the when the light catches it just right. So in this picture, you can see that this is normal, the red reflex. And every pediatrician appointment, they should check the eyes and look for the red reflex. When you don't get the red reflex, it's when you worry about retinoblastoma. Other signs are strabismus or blindness, which is a late sign. A lot of times, after a diagnosis of retinoblastoma, parents will look back in pictures and notice that they've had this white look in the eye. So here it is again, you can see. So treatment is typically enucleation, and what enucleation is they remove the eye that's affected. They also do chemotherapy and radiation, dependent on the case, but if the retinoblastoma involves both eyes, you definitely need to do both chemotherapy and radiation because you do not, because you really try to avoid taking out both eyes, because then you obviously have a blind patient. These patients after therapy, they do really well, but after, they typically do really well. About 95% of the time they're cured. But they should wear glasses for life, not because their good eye necessarily needs it, but you want to protect the one eye that they have left, because if something would happen, just normal kid stuff, get poked in the eye, if anything happens to that eye, they're not able to see the good eye. You should definitely know what leukocoria is for your exam. This picture shows the patient with leukocoria, and then later with their once the eye has been removed and they're and healed, you can put in the prosthetic eye. And these eyes, I have to tell you from experience, are so beautiful. Like, you really, a lot of times I couldn't even tell which one was the bad eye until I shined light in it. And it doesn't obviously react to light. The pupil doesn't react to light like a normal pupil does. So a lot of times until I shone the light in, you couldn't even tell which one was the bad eye or which was the prosthetic eye, because they are just so well done. Testicular tumors should be mentioned because testicular tumors typically happen in younger men. If they're found in adolescence, they are typically malignant, typically germ cell tumors. They are a painless testicular swelling. And this is why we need to teach every adolescent male to perform the testicular self-exam monthly. They should do it after a warm bath or a shower, when the scrotal skin is more relaxed and you can feel better. And the testicle should be firm, smooth, and egg-shaped contour. And there should be any abnormalities should be evaluated. So this is the end of the diseases. This is just a really brief overview because obviously this is a specialty, and there's a subspecialty. And when I worked in oncology as a nurse practitioner, I worked in solid tumor specifically. So it really is a highly complicated, involved specialty, as most are. And so at this point of your education, really you just needed an overview and not to get into a lot of the particulars. Our exam will be this Friday, the December 2nd. Since we're doing the testing class, we'll have some extra time. So before class, I can answer any questions you may have after listening to these recordings. We will see you on Friday.